آقای دکتر سلام عرض کردم. زویا آقای دکتر پریز.
Ali Reza?
Yes.
شروع کنید.
You wanted to start, Dr. Kita?
Yeah, I can start if you're okay with that.
Yeah, but we are just waiting for a few other people to come. If you
Okay,
don't mind, if
we
you are
can
not
wait.
hurry.
I
if you are
don't
not
mind.
hurry.
I'm not in a
Okay.
hurry. I'm not in a hurry. We can wait.
Okay,
We can
okay.
wait. Yeah,
Dr.
we'll
Pariz,
wait.
if you want to say something, you can say, or Dr. Hashimi also, or any other colleagues, would you like to talk?
آقای دکتر نواب، دوستان سوال پرسیدن که آیا این برنامه رکورد میشه یا نه، که شما
من خودم
رکورد
رکوردش میکنم. الانم داره رکورد میشه. بعدا
ان شاءالله اون رو توی گروه ها هم فایل رکوردش رو قرار خواهیم دادن.
چاش حتما.
خب ما الان 19 نفر داریم. فکر میکنم که
شروع کنیم. بله
20 نفر هستیم. آقای دکتر نواب شروع کنیم؟
بله آقای دکتر شروع میکنیم الان. با اجازهتون پس من اینو بیام بیرون. خب thanks to everybody and for joining this first web series of Iranian oral maxillofacial surgery. Today we got a special speaker, Dr. Krishna Murthy Bonati from India. He's known to me since 1986. He's one of my best friends, and I did my thesis on his guidance. He's a double degree. He got both a medical degree and dental degree at India. Then he went to UK and he got FDS RCS with FFD RCS. And he's a visiting professor at the University of Cincinnati, Ohio, USA, and they got the exchange program with the residency. Right now, he's the president of Indian Society of Cleft Lip, Palate, and Craniofacial Anomaly, that is ISCLPCA. and he was a president of Oral and Maxillofacial Association of India also. And one of his most important posts is Vice President of International Board for Certification of Specialties in Oral and Maxillofacial Surgery, that is IBCSOMS. Once I asked him and request him if it is possible to be held in Iran also. For young surgeon, it is very important to have such a degree. And he is the editor of Journal of Oral Maxillofacial Surgery India and Journal of Cleft Lip, Palate, and Craniofacial Anomaly. And currently, he is a director of a Smile Train project, treating cleft lip and palate deformity at Bhagavan Joint Hospital at Bangalore, and doing more than 600 cases in the year. His topic of interest is cleft lip and palate and craniofacial deformity and distraction osteogenesis. And today he is going to talk regarding the rhinoplasty in the unilateral cleft lip and palate. I am very thanks to him and thanks to our association who let us to organize with Dr. Parhiz such a program. And this is going to be one of our first, if anything happen or we have any problem in advance, I apologize to all of you. And I make Dr. Kita as a host to start his talk.
Thank you, Dr. Ali Reza.
You're welcome. Dr. Kita, now you are able to share your screen, and please go ahead. And once more, before you start, I should announce, if anybody got to any question regarding this topic, they can directly send to the box chat. Dear Kita, everything is okay? Dr. Kita, Dr. Kita, we don't have your voice. You are not audible.
I'm sorry, I was not mute. But did you get the slides on the screen?
Yes. We got the slides.
Oh, I had not unmuted. I'm sorry. I will start again.
No problem.
Yeah, sorry. I was unmuted. I was muted. Sorry.
No problem.
Okay, so we'll go back. Just can you see the presentation now on the slide?
Yes.
On the screen? Okay.
Yes.
Thank you very much. I'm sorry for not unmuting myself. On behalf of the Indian Cleft Society as well as the Indian Association of Maxillofacial Surgeons, good evening to all of you joining in from Iran. It's indeed an honor and a privilege to be talking to you all in these times of COVID when travel is not possible and the world has to do is to sit and share our thoughts and knowledge with each other, so that when we all come out of this terrible condition, the terrible tragedy that has befallen us, we will be more enriched, we will be more prepared for things to follow. I come from Bangalore in India, as Ali, my good friend, introduced me to you all. And today I will talk to you on the management of the nasal deformity in the unilateral cleft of the lip and nose. I was asked to write a review article in the Indian Journal recently. And when I was asked to give a list of topics, naturally, this was one of the things that I was interested in speaking to you all. I hope this topic will be of interest to you. And if you want to read our thought processes, understand it better, and also have a good review of the literature, you can always access this mini review in the Indian Journal of Maxillofacial Surgery, which is being published online a few days back. So let us look at the nose. We are going to focus completely on the nose in a unilateral cleft of the lip and palate. Oftentimes, this is something that is very easily forgotten because, as you see, everybody talks about the cleft of the lip, the cleft of the alveolus, cleft of the palate, but even in the nomenclature, the nose does not come in. But today, one of the important residual or secondary deformities that remains after we have done the primary surgeries is that of the nose. And therefore, it is important for us to understand before we talk about how to manage these deformities, when do we do it, how do we do it, why do we do it, what we do, etc. We have to understand what are the deformities that a child with a unilateral cleft is born in the nose. So I will not talk about any other issues, that of the lip, that of the alveolus or the palate.
Dr. Krishnamurti, you're disconnected. Dr. Krishnamurti. دکتر کیتا آقای دکتر پریز شما صدای منو دارید؟
بله من صدای شما رو دارم ولی صدای آقای دکتر قطع شده.
دکتر کیتا بذار من یه چت خصوصی بکنم باشه.
یه مقدارم در حین صحبتاشون صدا قطع و بس میشد. نمیدونم شما هم همین مشکل رو داشتی؟
نه من قطع و بس نشدم ولی الان کاملا قطع شد. من زنگش بزنم. اینترنت ها نمیدونم. ولی خودش باید اینترنت اون باید مشکل پیدا کرده باشه آقای دکتر.
بله.
Hi Gita.
بله.
Is there a problem?
Yes, we don't have we are not audible. You are not audible at all. And your slide also not changed. It is the same.
Oh, I'm very sorry.
You're welcome. You can go back and start again, no problem. Okay. I think something with your internet, maybe.
Yeah, possible. Let me just go back.
Okay. You again started again. مثل که مشکل از خود اوناست آقای دکتر.
بله.
اینجا مشکلی ما نداریم. شما که مشکلی ندارید. نه ما مشکلی نداریم. خوشبختانه 38 نفرم الان وارد شدن. برنامه‌های خود هند خیلی ما تا حالا که نداشتیم که اینجوری این اتفاق افتاده باشه، غیر اینکه الان یه مشکل
Can you see
سیستم.
now?
Yes, now your voice is
Can you?
clear. Everything is okay. Now you can start
Okay,
again.
let's go back.
Yes, thank
Okay,
you.
let's see.
What's happened? I think.
Can you make me? I don't know. Can you make me share the screen again? Make me the
Yes.
host again, please.
Yes.
Okay.
Yes, you are.
Okay, I'm really sorry about this.
You are
I don't know
welcome.
what
No
really
problem.
happened.
It is
Let's-
happening in during this time. All internet problem. It's happening for everywhere.
Yeah, yeah. Let me see. Okay, can you see me now? The screen
Yes,
now?
yes, yes,
Can you hear me?
yes. Of
Yes,
course,
yeah.
very clear.
Okay, thank you. So I really apologize for what happened, technical glitch. Basically, what I was trying to say was that we are going to talk only about the nasal deformity in the unilateral cleft of the lip and nose, and also that I recently wrote an invited review in the Indian Journal on this topic, and hence when Dr. Javani asked me to give some topics, this is one of the things that I gave her. So if you want any details, anything you did not understand, or you want more information on that, you can always access this journal, this article, and all the references in that. So the main problem with any unilateral defect like this is that of asymmetry. And here we are going to concentrate only on the problems of the nose. I am not going to discuss the lip or the alveolus or the palate, but just of the nose. And if we are going to correct this complex deformity, it is very, very important for us to understand what are the real problems. In other words, once we get a good understanding, once we clearly know what the problems are, then we can tackle these problems at whatever level. We will later on discuss how to do it, when to do it, and what are the methods of doing it. But first, let us look at the various anatomical problems that exist in a unilateral cleft of the nose. You will find the black lines there, two black lines, one shorter than the other. That is the discrepancy in the columella length. You have a longer columella or hemicolumella on the non-cleft side, which is the right side here, and a shorter columella on the cleft side. So a short columella is one problem. The columella, as you can see, along with the tip of the nose, the red line is also deviated towards the non-cleft side. And behind the columella is your nasal septum, which also is deviated. The caudal septum is deviated towards the non-cleft side, and the anterior nasal spine is also slightly deviated beyond the midline. All these problems occur because as the nose forms from the union of the two palatine shelves, and also from the septum developing from above, because the two palatine shelves do not unite, the nasal septum moves towards the side of the normal side, and therefore we get a deviation of all these structures, the columella, the septum, the anterior nasal spine, and you also find that the columella is shortened. Next, let us look at the shape of the lower lateral cartilages or the nostril rim. The shape of the nostril is given by mostly by the lower lateral cartilages and the alar base, and you will find that the lower lateral cartilages underneath the skin is stretched laterally. So instead of being nice and curved like you see here, it is elongated, flattened, right? So it is completely deformed, giving rise to a significant deformity. The flattened, elongated lower lateral cartilage in the color of blue. You will also find that the alar base here, marked with yellow, alar base is displaced downwards, backwards, and laterally. So the whole alar base, because of the stretch of the abnormal insertion of the muscles on the lip, not only is the alar cartilage is flattened, but the alar base is pulled downwards, it's pulled backwards because the lesser segment is behind, and then it is also more laterally placed than the alar base on the non-cleft side. So and then there is no nasal floor, obviously, no nasal floor because the palate hasn't formed completely, and therefore the floor of the nose is not present. To look at it in a different angle or a view, oops.
Oh, you put it down, yeah. You make dear Kita, you make a full screen and then.
Yeah, I'll do that. Okay, right? So look at it in a different angle now, okay? You can see with the blue lines, the columella is so short, it is resting on the lip. The whole of the nose on the cleft side is resting on the lip because the columella is very short. It's deviated, as you see on the red line. The flattened crust of the left lower cartilage, the displaced tip. The nostrils obviously are asymmetric. You find that the alar base, as I said, is displaced laterally, inferiorly, as well as posteriorly. There is no nasal floor, as you can see, the purple line. The nasal floor is missing, and the septum and the anterior nasal spine are shifted to the non-cleft side. And the number 10, which you cannot see here, I'll show you somewhere else, you'll find a hugely big inferior turbinate on the cleft side. So all these problems give rise to a severe asymmetry of the nose, and therefore it presents a big challenge. In fact, it is a much bigger challenge in producing normal results in comparison to that of the lip. So having understood what are the main defects that occur or deformity that a cleft nose presents with, the most important thing, this is something that has been very controversial, it has evolved over the time, is when do you do the repair of this cleft nose? Do you do it at the time you do the cleft lip repair at the earliest possible time? Or do you wait for a little longer and then do it later on? So based on when you do it or when it is advocated to be done, there are three different types of primary nose repairs or rhinoplasties. One is primary. Primary rhinoplasty of the cleft nose refer to the condition where along with the cleft lip repair, you do carry out the nose repair as well. The intermediate, first I will define the terminologies and then give some more explanation as to why there are so many different timings that are suggested. If you do a rhinoplasty when the child is still growing, oftentimes this is done just before the child goes to school, and it has been referred to as a preschool rhinoplasty. That is called as intermediate rhinoplasty. It might be done at the time of going to school or anywhere during the period from the primary repair till the growth of the jaw is complete. If you do a rhinoplasty, most commonly it may be done during preschool age. And then when everything has been treated, the child has grown into an adult. If there are deformities that need to be corrected, then you do a definitive rhinoplasty. People have also called this as a secondary rhinoplasty. And in situations, something that I have not added, in situations where people are not happy, you might revise it, what we call a revision rhinoplasty. I'm not going to talk about that today. So why primary rhinoplasty? Is that a common thing that is being done? This is the next question that we need to address. There was a time in the up to the 1970s and 80s, people did not do much to the nose. Most of them did not do anything at all at the time they repaired the cleft lip. There was a fear that in a small infant, when you operate on the cleft lip at 3 or 4 months of age, if you meddled with the cartilages of the nose, there was a fear that this will cause growth deformities. Particularly, surgeons were afraid of touching the septum because septum was regarded as a growth center. And there was a strong belief or feeling that the nose should be left behind and then should be repaired when the child grows up so as to not interfere with the various growth processes. However, this is a serious problem because however well you do repair the cleft of the lip, the cleft nose deformity can be very glaring, it can be very obvious, and as the child grows up, both the parents and the child have a lot of difficulties dealing with this situation of a severely deformed nose. And therefore, in the late 1980s and 1990s, people started working on the nose right at the time of the primary cleft repair. They also found out over a period of time as they followed these cases up that it was not causing any significant growth deformity. So there was a body of work that developed. I will show you some literature as we go along, a body of work that showed that it is not necessary to wait for the child to be grown up, to waste those precious years of the child's life when he or she has to face the psychological trauma of going around with a significant deformity, or also the functional problems like blockage of obstruction of the nose, etc., that this deformity might cause. So primary cleft rhinoplasty became an in thing towards the end of the last century. And for the last couple of decades, there are various different schools of thoughts as to how you can do. So once you decide that you can operate on the nose primarily, once we shifted from no job on the nose to primary repair, a lot of different approaches came in. Remember, as I've already outlined, these are very difficult deformities to treat, and people wanted to get better results and much better results and wanted perfection. So a lot of different schools of thoughts, therefore you find a lot of different approaches. So all those approaches that are described in the literature and practice today may be divided into these four categories: the non-surgical cleft rhinoplasty, repair of the cleft before doing the surgery, the classical pre-surgical orthopedics that goes by the name of naso-alveolar molding, that comes into this category. And then surgical approaches, it can be a closed rhinoplasty, an open rhinoplasty, or a semi-open rhinoplasty. Let's look at each one of them. So like I said, in the late 90s and following that, as people started doing and followed up patients, they found out that some work on the nose is important. And then came this particular technique of non-surgical rhinoplasty or naso-alveolar molding, which was popularized, originated in New York in the hands of the orthodontist Barry Grayson. And then they started training people in that, and they started collecting data. And people started looking at the results of the nose when naso-alveolar molding was done. And there are studies now that show that the symmetry of the nose is better if you just do naso-alveolar molding without doing any surgery at the time of the lip repair than to doing a conservative type of rhinoplasty. These are two papers that came in, one in 1999, the other one in 2010, this came from Taiwan, which looked at different methods of primary repair and found that if you did naso-alveolar molding alone without doing any surgery, you got better result than by doing a very conservative primary rhinoplasty. So what is naso-alveolar molding? If there's anybody in the audience who is not aware of that, it is a pre-surgical orthopedic techniques that is carried out by our orthodontists. You look at A, the nose in A has all the features that I described. And as we continue doing the procedure over a period of weeks and months, the stretched out lower lateral cartilage starts getting lifted up and it starts curving around. And if you look at E, for example, or F, for example, you will find that a lot of deformities that I spoke about is no longer there. The columella is now more or less straight. The septum is more or less straight, the caudal septum. The hemicolumella lengths are more or less equal. The lower lateral cartilage has gone up. The shape of the nostril has become more symmetrical. There are still deformities that are persisting. There is no nasal floor. The alar base is still more inferior, posterior, and lateral. But starting from A to C or D to F, you will find that over a period of few months that this process of nasoalveolar molding is done, there is an increasing degree of symmetry that is occurring between the cleft side and the non-cleft side without having put in a knife. And therefore, I called it as rhinoplasty, non-surgical. And this is something that has gained ground around the world. We have done patients with or without nasoalveolar molding simply because some of them turn up late. This has to be started off within first few weeks of life. And in our own hands, we found that there's a significant difference in the outcomes that with the noses when we do a nasoalveolar molding and we don't do. And it's quite obvious from this picture. I'll show you some examples of patients before NAM at finish of nasoalveolar molding before surgery in the middle and post-operative results after a few years. And you find that from a severely asymmetric nose, as you see in the left-hand side, to more or less symmetrical nose. Obviously, we are picking up good examples here. There may be cases where it doesn't work so well, but you will find that without having done any surgical procedure, it is possible to obtain decent nasal form and function with nasoalveolar molding alone. Another example, the first picture being at birth, the second one before the surgery. And when you do surgery, whatever other deformities were there, the alar bases, you brought them into the same level, coronally, laterally, etc., etc. So it is possible that at the end of the surgery, the nose looks almost symmetrical. What happens over a period of time is the next question that is important. Does it stay? You do all this work in a young child. Will the nose be the same for the rest of the life? That is $1 million question. We have been looking at this. We have very recently published this as well in the Indian Journal of Plastic Surgery. We find that as the normal side grows, this is one example of a case, as the normal side grows, the cleft side lags behind. And you find that, for example, if you take the columella here, the picture at the right bottom is at 5 years of age. You find that there is again a difference in the columella heights. The non-cleft slide is still little longer. And you also find that the cartilages and the alar bases are slightly at a lower level. In other words, as the child grows, we see that there is a relapse. So nasoalveolar molding is something which is very useful to correct the asymmetry and the nasal deformities when the child is born before the surgery. But experience is now teaching us that if you just did this alone, as the child grows, there's going to be some degree of relapse. It might still be better. We have just sent in a paper for publication where we show that it is better at 5 years, but it is not the same as it was immediately after repair. So what it tells us is that nasoalveolar molding is a good tool to start off correcting the nasal deformities. But in addition to doing that, you may have to carry out other procedures, probably surgically, in order to get the results more stable for a longer period of time. That's another example. Now, what are the other approaches that we can follow? All of them are surgical. There's closed approach, there is open approach and semi-open approach. The closed approach is the one that is very commonly used. This is a paper that was published in the Journal of Cleft Lip Palate Craniofacial Anomalies by a very famous cleft surgeon of India, Dr. Edenwala. And what you do here is that you try to access the cartilages of the nose from the incisions you have made on the lip itself, and you use dissecting scissors to separate the cartilages from the skin and the mucosa, and then alter the shape with additional sutures without exposing the cartilages in any way. That's why it's called as a closed approach. I used to follow this technique for quite a few years, but one of the problems that I had using this closed approach was that the results in my hands were not very predictable. Some days you would get a good results, some days not. And oftentimes when we saw them 6 months or a year later, most of the improvement that we had noticed on table had relapsed. So this is something that I will not talk to you in detail because my experience is very old and I don't have long-term follow-ups of those, but I do not advocate a closed approach right now. On the other end of the spectrum, there was Trott and Mohan, two surgeons. Trott was from Australia. They came up with an open approach. Like you do an open rhinoplasty in an adult, whether it is aesthetic or cleft rhinoplasty, they advocated that we open up and then fix the cartilages at the time of primary repair. And C. Thomas, who worked for many years in in Muscat, was a proponent of this, and he has published a number of papers. This one is one of them that you see, that he did hundreds of cases where he opened up the nose and then tried to fix the cartilage in the normal position. And this did not become very popular because this was a very drastic thing to do. People were not comfortable doing this in 3-month-old infants. They were worried that they will cause more damage to the cartilages as the child grew up. Here is an example of what open rhinoplasty approach that I have used in an older patient that I've operated primarily. So as you do the primary incision, you extend those incision into a transcolumella incision. In these cases, expose the cartilage, note how the normal side cartilage and how the slumping and flattening of the lower lateral cartilages on the cleft side. So this is quite easy if you were to be doing it in an older patient. In India, we had in the past patients who were operated much later in life, and we did try these open rhinoplasties on them at the time of primary repair. But what Trott and Mohan, what Thomas, etc. advocate is doing this open repair 3 months of age. I don't have any clinical experience with this, nor do I have slides to share, but if you refer to publications from C. Thomas, you will be able to get a good idea. Currently, what we do is a semi-open approach, and this was popularized by Philip Chen from Taiwan, and the Taiwanese group from Shangang Hospital did comparison between just doing a closed approach, doing just nasoalveolar molding, and also doing a open, semi-open approach as they called it. And this is what they advocate now, and I will try and discuss this semi-open approach of primary rhinoplasty in the unilateral cleft nose. So what we do here is, after finishing with the cleft lip repair, as you see in the second slide, you do the nose repair. On the non-cleft side, you make a marginal or a rim incision, and on the non-cleft side, because there is a slump of the tip as well as the slumping of the soft tissue triangle, you make what is called as a reverse U incision or a Tajima incision. With the help of this marginal incision on the non-cleft side and the Tajima incision on the cleft side, you dissect out the cartilages, free the cartilages, the lower lateral cartilage as well as the upper lateral cartilage on the cleft side from the skin and from the vestibule, and then use a 1 or 2 interdermal sutures to lift up the lower lateral cartilages. When you do that, you have some excess skin, you trim the excess skin along the reverse U and suture it in order to obtain a symmetry of the tip of the nose as well as that of the nostril size. So this is a technique which whose results have been analyzed along with the other techniques that have followed in the British Journal of Plastic Surgery in 2012 by Philip Chen et al. Now I will show you an example of a case of how we do the semi-open rhinoplasty as described by Philip Chen. This is a patient on the table. Most of the times in the past, where we did only nasoalveolar molding, we did not carry out any primary rhinoplasties. Only of late, we have realized that the relapse is there and that we need to do a rhinoplasty even in patients who have had nasoalveolar molding. But definitely, if you did not have the luxury of undertaking nasoalveolar molding, as we have in some of our cases, doing this rhinoplasty is a very good idea. So this is a patient who did not have nasoalveolar molding. So you can see on the table all the deformities that the child has when the child is born, it is still persisting. So you go and do your lip surgery. I will not go into the details of that. You will find that the tip of the nose on the cleft side is lower, that there is an increased soft tissue triangle there. The nostril height is lower on the cleft side, and you want to correct this by doing a rhinoplasty. Like I said, we will do a marginal incision on the cleft, non-cleft side. You can watch it for yourself. So marginal incision is also an infracartilaginous incision. We'll get in focus in a minute. Right, okay. So you mark the caudal end of the cartilage. It's an infracartilaginous incision, or what you call as a marginal incision. Strictly speaking, this is an infracartilaginous incision, and your dissection now, whether it is with the knife or with the scissors, should be on a plane just above the cartilage. It is difficult to feel because the cartilages are so thin, but the plane of dissection has to be above the cartilage, freeing off the skin and the smash layer, more or less blindly here, so as to gain access to the opposite side. That's what you do with this marginal incision on the non-cleft side. Try and free the dome of the cartilages, particularly on this side. And now we go on to the cleft side, where there is a reverse U incision that has been placed. Remember, the cartilage is very thin here. You have to be very careful when you make this incision, because this incision should not transect or go across the cartilage. This is only again on the skin and the smash layer that you need to do. Copious amount of local anesthetic infiltration helps in this. So this was first described by someone called as Tajima. So it's also called as Tajima incision. He wrote up a paper in 1982 describing this incision in the management of secondary noses when rhinoplasty was done on the adults. But Philip Chen and company used this for correcting the deformity in the primary nose. So it's a Tajima incision with the Chen's technique. So very, very gently, you raise a flap there, which is again skin and smash layer, leaving the cartilage on the nose, leaving the lower lateral cartilage on the nose. Most of this is by feel itself. Keep a good traction with your non-operating hand and gently, gently tease out this tissue, which has skin and the smash layer in it. So that when you start dissecting now, once again, your instrument is above the lower lateral cartilage. This time, the lower lateral cartilage as well as the upper lateral cartilage on the cleft side. Upper lateral cartilage on the cleft side is also deformed. Let's go and see how to do this now. So once you dissect on the lower lateral cartilage, you try to connect this tunnel so that you can freely pass whatever you are going to pass through them. Okay, go through the domes of both the cartilages, go through the upper lateral cartilage also, free it so that when you reposition them, they can move independent of the skin. Okay. So there is the skin structure above the domes, very, very clearly separated, so that you have created a nice tunnel now for a suture to be passed, an interdomal suture to be passed, to get the cleft side lower lateral cartilage in its position, as we see in this. So you start off on the non-cleft side, take the vestibular flap, which has got the cartilage in it. Remember, we have not separated the lower lateral cartilage from the vestibular skin. We have only dissected it from the nasal skin. This video shows me using a Y-krill, but I've switched over to a 40 PDS suture. PDS is a little more smoother, lasts a little longer. 40 PDS, but this one is a 40 Y-krill. So come through the tunnel to the opposite side. So it's basically an interdermal mattress suture along with the vestibule to elevate the lower lateral cartilages to where they should be. Okay. Now you start passing the suture through the cartilage, which is still stuck to the vestibule. Take it more laterally than what you do on the opposite side. Remember, this is a cartilage that is stretched laterally. So in order to shape it, you pass this needle out of the cartilage more laterally on the cleft side, and now you go back. Now we go back to the opposite side. So having passed, so we do the reverse procedure through the skin, the vestibular skin and the cartilage on the cleft side. As you see, as you lift the thread up, you find that the cartilage starts lifting up. The shape of the nostril gets more symmetrical. Go past through the interdermal tunnel that you made earlier to the normal side, back again. And then pass it through the lower lateral cartilage as well as the vestibular skin on the non-cleft side. And then
need a skin hook now. Just a couple of seconds only.
So it's just a mattress suture, an interdermal suture that takes the cartilage along with the vestibular skin using a absorbable suture material, preferably
Give me a wet cotton
PDS
and then a skin hook.
suture. Okay.
Oh, wet is wet. Okay, skin hook.
Right. Now, as you tighten this up, you hold the lower lateral cartilage flap with the skin hook in the position that is desired. So what we have done with this is we have lifted the lower lateral cartilage and given a better shape, resembling the opposite side to that of the lower lateral cartilage of the on the cleft side. And then I'm sorry, the other step is missing. There is excess skin there. Just drape it back, and whatever is excess, trim it and put sutures on the edge there. All you see now is just a web that is remaining. The columella are both equal in size. The domes are in a similar position, and the nostril height is more or less the same. This is an example of a patient about 6 months or a year later, where he has undergone nasoalveolar molding. As you can see, these are pictures after nasoalveolar molding. Typically decent looking nose even before we operated. And then he has undergone a Tajima incision. If you closely look at it, you will find that Tajima scar, but in most cases like this, it's virtually invisible. This is a big fear that I had while I was raising these Tajima incisions in infants in the beginning, but they seem to heal quite well. So I think, so I have missed out on one slide here. One of the other important things that we do, let me just check and see whether I can find that slide. One of the important things that we do is also do the use of what is called as a nasal conformer. I had a slide of that which appears to be missing in this one. Let's just see. Okay, I'm sorry, just give me a minute.
It is okay. Take your time, doctor.
Yeah. This is something that I added in the last minute. I don't seem to find that. I will show it at the end of the presentation. So,
okay.
yeah. So this is something which is another additional thing that you need to do after you have done all of these. So you've done nasoalveolar molding. You have done a semi-open rhinoplasty. You still find that after some time, you follow them up, there is relapse. So one of the important things that we need to do is to, in order to preserve the results that you get, is to use what is called as a nasal conformer. I apologize, I put it in at the last minute. I will find that slide and show it to you in a minute. So when you do the nasal conformer, it holds the nostril in that position, and we ask the parents to use these nasal conformers for about 6 months of age. Okay, all right. Let me just, I'm not happy without showing that. I'll just show it to you in a minute. Okay, can you see this slide?
Yes.
Yeah.
Okay.
So this is what is important. So the first slide is before doing the rhinoplasty, lip repair, after lip repair. And after we do the rhinoplasty, as I showed, you use a silicone flexible airway kind of thing. There are ready-made conformers that are made by a Japanese company called Koken, but we use our own improvised ones, nasopharyngeal airways. And you take a size that fits into the normal nostril and use it on the opposite side as well. And what we do is, once we put this conformer in place on the table, we secure
Dr. Kita, you are not, we don't have your voice, Dr. Kita. You may mute yourself. Is it? Dr. Krishnamurti? Yes. Dr.
مثل اینکه
Krishnamurti?
دوباره قطع شدن چون میوت نیست.
نه میوت. الان زنگ میزنم دکتر.
Can you hear me now? Hello?
Yes, doctor. You are okay. You are audible.
Okay, thank you. Thank you. I don't know why this is happening. I apologize once again. So we go back. Can you hear me now?
Yes, of course.
Yes, we can.
Yeah. So as I was saying, intermediate rhinoplasty is something that you do while the child is growing up.
Dear Kita, I think you have to share your PowerPoint. Wait. Now.
One second, Praveen is calling me. Let me check what is.
Yes, I told him to help you. That's all.
Praveen, enta problem? Okay. Oh, okay, Praveen. So can you hear me now?
Yes, Dr. Kita, you have to again share the screen.
Oh, share the screen. Okay, okay. I'll do that.
Yeah.
Share the screen. Okay. Yeah. Okay, we'll come back. I'm really. Can you see my screen now?
Yes, yes.
Can you hear me?
Yes, of course.
Okay. So you saw the picture on the conformers, right, Dr. Ali?
Yes, yes.
Okay. So
But
intermediate rhinoplasty.
make it
Yeah.
full screen.
Make it full screen.
Slideshow.
Okay.
Yes, yes.
Okay, 1 second. So what I was asking is, did you see the slide on conformers before
Yes,
this?
yes, yes. Regarding the nasopharyngeal airway, you are going to make yourself.
Yeah,
Yes.
yeah, yeah. Right,
Yes.
right. You saw the pictures. Okay.
Yes.
So
yes.
intermediate rhinoplasty is something that you will do if the nose is looking very bad and the child is having problems at school or is likely to have problems at school. This is a limited approach. These are pictures that are given to me by my colleague from Trichur. You just work on the lower lateral cartilages at the same time, like we showed earlier, or you can even do an open view, but you don't do a definitive repair. Remember, the child is going to grow. He or she will need a final rhinoplasty. But this can be done at any age, from the time of primary repair till the child's growth is complete, if the psychosocial concerns require it. But in most instances, whether you have done a primary repair or intermediate repair or not, there will be some deformities that will be still remaining when the growth is complete. And then if the child so desires, not everybody asks for it. I don't know how it is in Iran. In our country, a lot of people are quite happy with milder deformities and they don't seek a rhinoplasty. But if they seek, you will find whether you've done a nasal molding or a primary rhinoplasty or you haven't done anything, there will be deformities that are there. And at this point of time, you can do a definitive rhinoplasty. So in an ideal scenario, if we have done whatever we have done so far, these are the problems, or this is the condition that we expect. That upper 2/3 of the nose we haven't touched. Remember, whatever we saw, we dissected on the lower lateral cartilages, the septum, the upper lateral cartilages, but not the upper third of the nose. It is also assumed that the skeletal base at this time is well balanced, which means we have done the alveolar bone grafting. We have also done an orthognathic or a distraction procedure in case the maxilla was hypoplastic. In other words, this is a procedure, a definitive rhinoplasty is something that you will do right at the end of all the work in cleft is over. Child is grown up, growth is complete, you've done the grafting. If required, orthognathic surgery has been done. The skeletal base for the nose is now more or less symmetrical. And there is the ala on the cleft side is slumped only minimally and moderately. And most importantly, you have not left the cartilage in a damaged stage. Sometimes when you do open, you find that the cartilage is in tatters or pieces from previous work. So this is something that we have to be careful when we do surgeries in a younger child, because when we finally open it up for a last definitive rhinoplasty, you want to see the cartilage in good condition. And also the scarring. Remember, I was talking to you about the worry of scars that you may produce from a Tajima or whatever other incision that you made. So you want to be in a situation where the skeletal bases are in their normal position, that the cartilages and the skin is minimally damaged. So this is an ideal scenario where we have done a nasoalveolar molding and the primary rhinoplasty, but in the real world, you don't see it often. A lot of adult cleft noses have had nothing done, and therefore you'll need to do a full job here. Now the question, I know that in Iran, rhinoplasty is quite an important procedure for facial surgeons to perform, that there are excellent aesthetic rhinoplasty surgeons in Iran. When it comes to cleft noses, the question that we need to keep at the back of our mind is that, can we get excellent results in this? Remember, there are deformities, there are scars, there are growth issues, and so on and so forth. And to be able to deliver noses that look completely normal or beautiful may not be possible. And therefore, it is also to be remembered that your patient, whatever work you do, may be left less than satisfied after you have done all your hard work. So it is extremely important for us to understand what we can achieve from this surgery, and also to understand the expectations of the patient and do not raise their expectation to a very high level. How you do it will depend on your own cultural backgrounds, etc. And I, for one, always play down the expectations of the patients, because I know that the post-op results may be much better than the pre-op, but it may not be exactly the normal or the way the patient wanted it, particularly with these difficult deformities. Now, once you have decided to take this on, a very easy question to answer in cleft nose rhinoplasties, whether you do an open approach or closed approach for a definitive rhinoplasty, there is no doubt virtually nobody does a closed rhinoplasty. Once again, because of the difficulty that are likely to encounter, because of the extent of deformity, the presence of scar tissue, etc., it is not going to be satisfactory if you open a closed approach. So most commonly preferred approach is open approach to a transcolumellar incision. Now, once you have exposed the cartilages, what kind of structural repair do you do? There are two main schools of thoughts here, and which overlap to varying degrees. One in one extreme is where cartilage is used everywhere. You use a cartilage to give support to the columella in the form of a columellar strut. You give support to give overlay grafts on the alar cartilages. You do septal extension grafts. You do tip grafts and so on and so forth, dorsal graft and so on and so forth. And a whole lot of cartilage is used in order to provide the framework for the nose, and it is often successful. On the other end of the spectrum is where people use very little of the cartilages, who believe that the structure of the nose can be improved. It can be brought back to its normal position without the help of cartilages, where a lot of suturing and stuff is used, dissection and suturing is used, and the results are maintained with the use of post-op conformers, etc. And many people come in between, where they use some cartilage work and some amount of suturing techniques, etc. Grafts can be taken from the concha, they can be taken from the septum, but if you require more cartilage, you want a dorsal graft, the usual site for obtaining a graft is the costal cartilages, right? For lack of time, and since this is a lecture on a complete management of the nose from birth to adulthood, I will not dwell into the details. I tend to work on the less cartilage principle. Here is an example of a rhinoplasty that we did carry it out along with orthodontics as bone grafting and lip revision for this patient. From left to right, she has undergone orthodontics, bone grafting, lip revision, as well as a rhinoplasty. She was a borderline case for orthognathic surgery and did not undergo orthognathic surgery. If you look at her from the basal view, so you will find these kind of deformities. Before you started off, the nostril height is smaller, the lower lateral cartilage is slumped, the alar cartilage position is little more lateral. And when we have finished, though we have not obtained symmetry on all levels, you will find that the columella length is more or less the same, that the tip of the nose is restored, that the symmetry of the nostrils are more or less same, except that in this case you find that the cleft nostril is a little wider. Another example of rhinoplasty that has been done with the minimal use of cartilages, you find that there is a significant deformity. You find there is a tip is what we call as a ptotic tip hanging down. The lower lateral cartilages are in a significantly lower position before doing the rhinoplasty. It has to be noted that she has also undergone a lipo-1 advancement for a mild maxillary hypoplasia, and that's how she looks from an inferior view. Much better symmetry that has been obtained. There has been some amount of widening of the alar base as a result of the maxillary advancement in this case. And here is an example of what extensive cartilage work can do. This is a patient who also underwent maxillary advancement at the LEFO1 level before undergoing a definitive rhinoplasty. If you look at the basal view, you find that the lower lateral cartilages are significantly slumped, that the nostril orientation is completely horizontal. She has a significant degree of ptosis of the tip. All this has been corrected here with extensive cartilage work, with columella strut graft, dorsal augmentation grafts, as well as septal extension grafts to get results like this. Oftentimes, you will also find that whether you use a lot of cartilage or otherwise, the results are less than satisfactory. One of the reasons here is the problem with the soft tissues. If you are operating in a very scarred field, in other words, the soft tissue that is available for you to redrape the nose after you have repositioned the cartilages, it's not of good quality. You may, whatever effort you do, minimal or extensive, you may end up with poor results. So this is something, definitive rhinoplasty is something that can be humbling, can be difficult to do. However, we believe that if we follow the principles of early intervention in the form of pre-surgical orthopedics, in the form of a primary rhinoplasty, definitive and if we have not damaged the tissues to a great extent, these definitive rhinoplasties will become easier in the coming years. And the hope is that not only that the child will grow up feeling more normal, but also at the end of the day, we will be able to produce more satisfactory results. That is the hope. So I apologize for all the interruptions that we had, but we have managed to reach the last slide. The take-home messages from my side. The first most important thing is to understand the deformities. There are a large number of them in the columella, in the septum, in the lower lateral cartilages, in the alar base, in the position of the tip of the nose, in the nasal floor, etc. And once we understand the deformities, then we can have a plan as to how to do it, when to do it, etc. And I would recommend that we do nasoalveolar molding. It's an extremely important, non-invasive, non-surgical method to improve the symmetry of the nose, particularly in a unilateral cleft lip. Also the position of the septum before you put your knife. And current practice for me is to do a primary semi-open rhinoplasty even in the presence of nasoalveolar molding. The improvement there is not as significant, but if you do not have nasoalveolar molding in your repertoire, then I would definitely recommend a form of more extensive, like a semi-open or an open rhinoplasty for your patient. Intermediate rhinoplasty or preschool intervention may be needed if your work has been more than satisfactory. It's possible that you will be doing less and less of this. Remember, lesser the number of intervention, more easy it will be to get our results at the end. And therefore, this is not something that has to be done, but these are done in cases where the deformity is quite severe and is causing a significant psychological concerns, particularly to the parents, even before the child feels it. And oftentimes, it is done as a preschool procedure. Most of the times, the definitive rhinoplasty, which is the final step, which is the most extensive step, is usually done after the growth is complete. After the growth is complete, making sure that the skeletal base is in its normal position. In other words, whatever bony work required has been done. And then once again, you do an open rhinoplasty, identify your deformities, correct them either with repositioning of the cartilage available or by taking help of autogenous cartilage grafts from elsewhere for your reconstruction. I hope in the last 1 hour that I've been trying to talk to you, I've been able to give you a summary of what I believe are the important principles of management of the nose. I would be very happy to take questions, if any. Thank you very much.
Thank you, dear Krishnamurti. Very nice presentation. And this interruption is as usual for the internet problem. There's not a matter. A very, very nice presentation. I want to ask our colleagues, anybody want to have a question, you can on your video and mic, unmute yourself and talk, ask your question. Before starting our question, I got one question from you, Dr. Kita. Anybody in the child age, in the growing age, will touch the septum, nasal septum for the deformity or not? We are not allowed to do.
Yeah, so
yes.
So thanks, Dr. Ali. Yeah, this is something that I forgot to mention. So if you have done a nasoalveolar molding, the septum usually is in a good position. I don't touch it. But in the absence of that, what we do is we do release the septum from its bony attachment caudally and then bring it to the midline. Yeah, so, because this is something that, yes, when you do the muscle suture, you can fix it in the midline, just one stitch. So you just separate it from the nasal floor, separate it from the normal side. So remember, it is bending down to the opposite side. So you free mucopericondyal flaps from both the sides, detach it from the nasal floor, bring it to the midline, and when you close the nasal floor or the muscle sutures, put one stitch to keep it in the midline. People have followed this up. I don't have data for this. A lot of my patients do nasoalveolar molding and then I don't touch the septum. But people have data to show that the septum grows more straightly. So later on, you may not need an extensive septoplasty. Also that the nasal function is better, that they have less chance for obstruction of the nose. You know, one of the problems that these children come with, if there is significant deviation, is that they get significant obstruction, which can interfere with normal breathing, and you may have to do a septoplasty early on. Yes, it's worth doing a straightening of the septum at the time of primary repair. But if you do a nasoalveolar molding, the septum is almost straight. I can see Dr. Miazzini in the group. I want to know whether she wants to take this question on. Dr. Miazzini?
Unmute. Can you hear me?
Unmute. We can hear you.
We haven't done any studies though, so I have no evidence.
Right.
Their perception is that after nasoalveolar molding, you definitely get a straighter septum, but and plus I've been doing a lot of bilateral nasoalveolar molding, but I've only started 5 years ago to do it unilaterally. So I really don't have enough evidence as yet.
Yeah. Yeah.
Just
thank you. So
it looks better.
Yeah.
I told you last time, you're the only one who can write the evidence.
I'm going.
And you should.
Yeah, we have not measured it, but we will do it soon. Yeah. Yeah. I see it in every single case. The septum appears straight. How it is behind at the vomer, I don't know. We will have to look at it.
Yes.
But the cartilaginous septum is always straight. Caudal and the cartilaginous septum. Yeah.
Professor Maria, thank you for joining us, and thanks for participating in the question. My question actually was, if we touch the septum in the growing child, it will cause any problem for growth of maxilla in the later or not?
Right. So current evidence suggests that it is not a problem.
Not a problem. Thank you so much.
If I may say, Professor Brusati has been doing since 2006 septal repositioning during primary surgery, and that is the only thing that I am studying, and there's no difference in terms of growth.
Right.
Thank you.
Yeah.
Thank you so much.
I'll go away.
No, you'll be here. You'll be here. We need you. Dr. Paris and Dr. Hashemi, if you have any question regarding the speak today, we will be happy if you ask.
Thank you, Professor Krishnamurthy, for your nice presentation, and thank you, Professor Maria, joining us in this presentation. I remember you were here in Iran 2 years ago, and we were very very pleased to see you here. I'm waiting for my friends to ask any questions. دوستان اگه سوالی دارید بپرسید که میتونید وایس رو باز کنید یا تصویرتون رو باز کنید و سوالتون هم بپرسید.
آقای دکتر هاشمی
جانم
عزیزم، سوالی چیزی؟ آقای دکتر وفایی هم هستن، چند تا از جراحان جوانمون هم هستن، اگر سوالی داشته باشن خیلی خوشحال میشیم.
دکتر محمدی هم همینطور.
I would like to have a special thanks to Dr. Krishna. I didn't perform cleft lip for several years and it's not my field, but I enjoy it and thank you very much, Professor. Thank you very much.
Thank you, sir. Thank you.
استاد رهسپار خانم دکتر محمدی اگر سوالی دارید منتظرتون هستیم. آقای دکتر خیابانی.
آقای دکتر خیابانی شما که خیلی کار میکنید توی این رشته، سوالی چیزی؟ میکروفونتون رو آن میوتش کنید آقای دکتر خیابانی، میکروفونتون رو باز کنید و صحبت کنید. آقای دکتر رهسپار، آقای دکتر برزگر.
Hello to everybody. Hello everybody.
Hi.
Thank you very much, Professor Shamordi, that for your participation in our event, and also again thanks for your coming to Iran. We have a center in the south of Iran, and we do a lot of surgery for the cleft lip and palate, especially with Dr. Najmi. We based this center, and yes, he started to do surgery and managing this center for us. And for most of the patients, we do the nasal alveolar molding and also correction of the alar cartilage as early as we do the closing the lip. And we never touch the septum. And we found that after a few months, then when you're correcting the form of the alar base, you can see that how it is straightened, the septum, without any touch, without any surgical management. And because, we accept that septum, especially it's in suture with the maxilla, is one of the most important part for the growth of the maxilla. And because of that, we prefer not to touch the septum, and we see that how it's corrected with the nasal alveolar molding and also alar correction.
Yes.
And also the growth of the maxilla is not impaired, and we see many patients now there is no maxillary deficiency or maxillary growth impairment.
Right. Thank you.
Yeah.
I agree with you, sir.
Welcome.
Thank you.
Welcome.
Any other question from audience? Any other question? I think there is no any other question. Dear Krishnamurti, I will be very thanks to you in behalf of our Association of our Maxillofacial Surgery from Iran, and hope we will have continuing this web series with your help and your other colleagues in the future. And thanks, Dr.
Absolutely.
Maria, which joining
Absolutely.
us. Thank you so much. If you have any things to finish and your talk, I think there is no more question. Thank you so much.
Thank
Thank
you.
you, everybody.
Bye-bye.
Thank you.
Bye. Thanks. Bye-bye.
Thank you so much. Bye-bye. Thanks to everybody.
Thank you, everybody. Bye-bye.
Thank you. Dr. Asapar. Hello.
برنامه فردا شب رو هم فراموش نکنن. یه برنامه هم فردا شب داریم.
بله
با آزینی. اونم برنامه خوبی خواهد.
بله.
موضوع اون چیه آقای دکتر؟ سلام شد.
اون هم در مورد نقش ارتودونتیست‌ها در درمان کلفت لب و کام هست.
بیشتر در رابطه نمه دیگه، نه آقای دکتر؟ در رابطه نمه.
خیلی تکنیک جالبی دارن. قرار شد که با آقای دکتر پرویز با انجمن ارتودنسی هم یه هماهنگی بفرمایید، فکر کنم برای اونها خیلی جالب
باشه. حتما.
آقای دکتر اسفر، منم دادم اغلب جواب بچهای ارتودونتیستا که توی گروه‌های خودشون بگذارن، باید کمی تبلیغات بیشتر بشه. ولی خوشبختانه این برنامه زوم که من درست کرده بودم امروز جوابش الان اومده که تا 24 ساعت دیگه، فکر کنم دیگه فردا شب میتونیم برادکستش هم بکنیم، بذاریم روی یوتیوب هم آنلاین باشه که اگر تعدادم بیشتر از 100 نفر شد راحت میتونن همزمان ببیننش، که لینکش رو منتها وقتی که شروع میشه میتونیم بذاریم توی گروه. بلافاصله برمی‌داریم میذاریم توی گروه واتساپ.
همون موقع.
بله همون موقع میذاریمش توی گروه واتساپ.
خیلی
ممنون، خیلی ممنون. فقط آقای دکتر دزافتی من گفتم چرا نیومدی، گله کردن گفتن هیچ که به من نگفته. این باید یکمی تبلیغاتتون رو بیشتر بکنیم. حالا این کارا همکاری کنن، این برنامه به خوبی برگزار بشه. به هر حال انجمن فتح و صورت ایران کم نیست، یک انجمن بسیار بزرگ و خوب و خدا رو شکر بهترین جراحان فتح و صورت هم رو داره و بیشتر باید شناخته بشه تو دنیا.
بله.
خیلی ممنون از همه تون.
مرسی با دیدارتون.
قربان شما. خدا حافظ.
مرسی، خسته نباشید همگی. خیلی ممنون. مرسی.